Good morning. Thank you very much, Tariq. For Dr. Peeperkorn, please, if maybe you can give us an update, because these figures are up to end of July, as you said, and maybe we can have an update on what happened during the month of August. How many more injured people do you estimate there are in Gaza? And also, if you could, you are able to give us a breakdown of how proportion of children and women with life-changing injuries are in Gaza now. Thank you.
Thank you, Isabel. So I don't know if Pete or Rick, who would like to take this one?
I think let Pete start if I need to add something, because he has been really doing the most of the analysis. And I can just say that I don't think at the moment we have the specific updates, like how many more injuries. And there is updates, of course, on that. I don't have them here by hand, but of course there are updates, because unfortunately, and I want to maybe get back on that later, although we are in a little polio bubble with area-specific humanitarian pauses, etc. When that finished, we unfortunately have seen ongoing bombardments, as you saw in Mawassi, and I think in Nuseirat, etc., and other places. So Pete, maybe first over to you, and maybe Thanos wants to add something on that.
The official figure I think we have at the moment is just over 95,000 people injured. So still an ongoing increase, no let up, I think, in terms of the number of injured and the scale of injured people coming into these facilities. So if we apply the 25% statistic to that number, that would be 24,000 people now with life-changing injuries. And I think we're safe to assume that the percentage assumptions remain the same regardless of the total number of injured. I'll pass to Thanos if he wants to come in.
Thanks, dear Pete. Thank you for the question. Figures of additional injured people can easily be found. We are updating our situational report every week. Right now, I don't have it on the tip of my fingers. However, what is essential for everybody to understand is that the conflict is fierce, it's ongoing, and we continue to have a huge number of people that get severely injured during this fight. Over.
I think the most important thing is for all, and I think that is coming from this analysis, that you talk about 1/4 of the total people injured. And that was by July, the 1/4 was 22,500. So now, and rightly as Pete said, it will be something like 24,000. But with this, let's say with the ongoing war and the way the nature of the injuries, as the assessment was that 1/4 of those injured have these life-changing injuries that require rehabilitation services now and for years to come. And that, of course, is pretty shocking. Over to you.
Thank you all. So that's Dr. Thanos Gargavanis, trauma surgeon emergency officer. We will send the full name and title in the email with opening remarks of Dr. Peeperkorn and with the video link, so you have it as well, as we did not have it in a media advisory. Let's go now to the next question. John Zagakostas, who writes for Lancet. John?
Yes, good afternoon. Thank you for this briefing. Just following up on the question by Isabel, do we have from the data that you collected the breakdown, how many of the amputees are children and also with life-changing injuries? And Rick mentioned it's until July, but I think your report data set says from 10th of January to May. Is that the data set and the rest is extrapolations? I'm a bit confused there.
Thank you, John. Maybe Pete can answer these two questions on breakdown, if we have numbers of women and children, and on the dates.
Unfortunately, the data set that we have isn't on an individual level, so we're not able to go down into the level of granularity to give sex or gender disaggregation within the set that we have. But we do know a significant number of those affected are women and children.
Thank you. Thank you very much. Next question, Anadolu News Agency, Beyza Donmez. Beyza.
Hello, thank you. I would like to ask about polio vaccination and to the Dr. Peeperkorn, of course. I already know that he shared the figure about the North so far, but what I want to know is what was the target for WHO to reach in the North? And how the delay on September 9 and the fact that some areas in the North fell under evacuation order affected those numbers. Like the World Health Organization is expected to reach its target, or it's going to be lower than expected? Thank you.
Peeperkorn?
Yeah, let me start. I don't know if Deepak, Dr. Deepak is online as well. He's the WHO polio's specialist, actually coming from the regional office and been working with the teams for weeks, etc. And with me, he was in the North, and he actually went back to the North again yesterday. So he might also. So I think that, let me say, the most important thing is that's what we have up till now. Up till now, actually in the North, we vaccinated 105,000 children and 908. Today's figures have not been included. We saw on the first day in the North something like 89,000, then 89, yeah, I think 81,000, then 24. So we expect maybe today another between 5 and 10,000, but that will be not more. We see this also in other regions. It tapers off very quickly after the first day. The second and the third day are considerably less. The targets, and I think it's a good point, because we have seen this in the past, where we, for example, had a target for 55,000 in central area, and we over-vaccinated. We came to 180,000. And then we described that mainly that there was a lot of evacuation orders in that region before over the weeks before. And so more people actually moved to that area than we expected, and also some people from the south. Okay, overall, I mean, this polio campaign has, and the technical committee did a fantastic job to actually set it up so quickly. This incredibly complex, and having worked in Afghanistan for 7.5 years, been involved in many campaigns, and they were very complex. They are very complex there, but this was probably the most complex one in that sense. They had to quickly and come with a target. So they intentionally also set he maybe set a bit overestimated the 0 till 10 years to make sure, first of all, that we have enough vaccines in place, vaccine carriers, and everything around. That was one. What is more important in polio, specifically in a country or an area where you do it for the first time, is the so-called post-campaign monitoring. Then you analyze, you do an assessment everywhere you've been. You analyze, first of all, of course, how many of the children have been vaccinated, and you extrapolate that, so you get a better overview of the actual coverage. It also extrapolates it to the actual target number, the actual number of children there. There were some other complications, and I think I've raised that in some press conferences before, that normally when you do a polio campaign, you do house-to-house campaign. And before that, you do all the estimates per block, and you go house to house. And that matches very closely, 90 to 95%, to actually the actual children which are there. We couldn't do a house to house because there are few houses left, and people have been moving constantly. That's why we also had to use many more fixed sites, what we normally would like to do, and mobile teams. Also, I think we should not forget what we understand. So roughly 150,000 people have left Gaza since the war and everything started, this crisis started. So we might have overestimated. it's really, really important that we do this post-campaign monitoring well. And I want Deepak to come in and explain a bit on the specifics of that. But overall, I think with the technical committee and myself, let's say we are happy with this polio campaign. And I think we are also quite confident that we reached an enormous amount of children in this short time. And I think we are confident that we probably reached the target. What we want to reach 90% plus of our target, and then repeat it 4 weeks later. Deepak, you want to come in a little bit on the numbers,
Yes.
a little bit on the post-polio campaign.
Thanks, and greetings, colleagues from Tiralwala WHO. So, I mean, in continuation to what Dr. Peeperkorn has mentioned, I would like to highlight a couple of contexts here before I respond to the question specifically. And the first thing that we all need to agree and understand is that in Gaza, the context that we had at hand before the start of the campaign as part of our preparations was a highly dynamic and fluid situation. The population were constantly moving, not even every day, but by every hour. And that presented an immense level of challenge in terms of mapping the population and also correctly estimating the population sizes in each locations. One of the idea that we had, and that is the approach used in most countries where we have the polio campaign started for the first time, because in this area the polio campaign was not done for a significant period of time for long, and only the routine immunization coverage were very strong and were accounted. Now, when we started the campaign, there was an estimation, and like Dr. Rick was mentioning, that there was an overestimation based on the statistical figure, which is fine, since based on that, we had to start the campaign, and now we have a more corrected value of 552,000 approximate children that we would use as a reference target for the next campaign that we would have 4 weeks later. Now, another thing that I would like to specifically mention here regarding the campaign is that when we look at the vaccination coverage, we saw that around 78% coverage was met by covering population under 10 children in Deir al-Balah and Khan Yunis, these two important and big governorates in the middle and south. The remaining from the north, because the question came from the north. So in north, we have so far, right now as we speak, the third day of the campaign is still going on. But for the 2 days, we have the cumulative figure that contribute to approximately 18 to 19% of the entire coverage result of 552,000. So yes, we have been able to do impressive campaigns like Dr. Rick was mentioning, and it is an incredible feat right now from all fronts, from the partners and from the polio vaccinators, supervisors. There are more than 1,200 teams that were working in different phases. And most importantly, the community that expressed very high level of enthusiasm in bringing the children to the different vaccination sites that are located different during the phases. And we saw invariably and consistently that during the 3 phases we had, during the first day of the vaccination, in each of the 3 phases, there was a huge turnover of families bringing the children with enthusiasm. The last thing on the north, there are humanitarian pause zone, and outside this humanitarian pause zone, we knew that we have some estimated population that are living, and that were actually reached through predestined fixed vaccination sites where WHO missions were carried out. WHO missions dropped vaccines, vaccinators, and also cold chains and supplies, etc., so that the campaign could happen even in those areas. Certainly, there were certain limitations, and they were all coordinated. But in those campaigns, those activities in such areas outside the humanitarian pause were closely reviewed, and the data was watched over very closely until we were confident that we have reached more than 95% of coverage, which we are today. Over.
Thank you very much, Deepak. This was Deepak Kumar from who works on a polio campaign in Gaza, polio vaccination campaign. So we will also send his name and title once we send the package after the briefing. Let's go back to John Zaracostas. John, do you have a follow-up question?
Yes, I do actually. I was interested. I think Rick mentioned that only 13% of the medical needs of the people with severe injuries were being met. What is the cost to have all these needs met? And secondly, you mentioned that 39 physiotherapists had been killed. How many physiotherapists are on the ground now in Gaza? Thank you.
Pete, Rick, who would like to start?
Well, maybe I can just start. And John, I think they're all excellent questions, and really, really mean it. I wish I could address this everything. So, like for WHO, we, as you might have, and I think I shared it with you. Otherwise, we have to share it again. So, when this crisis started, we immediately made a plan, and that was, of course, for our humanitarian health response from actually October till March. Then from April till the end of this year, end of 2024, we updated that plan. We made a new humanitarian, well, a new WHO operational response plan, where we added one pillar. The 4 pillars, which remained the same and was very much part of the humanitarian WHO, humanitarian health response, were of course essential health services and everything from primary healthcare, community health, referral care, EMTs, etc., related to that. The second pillar was everything related to public health intelligence, information systems, epidemic control. Well, the third pillar, which is fortunately probably a large pillar in volume of resources, is medical supplies, essential medicines, the whole operation supply logistics, what would be required. We talk about, of course, medical supplies, essential medicines, medical consumables. And when I'm here now, the last 2.5 weeks, both here in the south and in the north. So from the let's say the health workers, hospital directors, what I'm told now that yes, they need all those specifics, but what they most need is fuel still to run their hospitals, but also very simple things. How to maintain their generators, specific oil for their generators, filters, etc., which we have difficulties getting in. The fourth pillar, where we always focus coordination and everything coordination of partners and everything around that, and the health cluster and all the health cluster partners. And the new pillar, which we included, was of course early recovery, rehabilitation, and reconstruction. Now, up till the end of the year, only for WHO, we came to 500 million or something like that, and 200, 300 was for this early recovery. And this is just, it's a drop, because I mean the real assessments and from the clusters, the overall clusters, it's a multiple target. So it's a small part of that. So I cannot give you what would be the costs related to that specifically. And your second point, John, was on the. Can you repeat that? Your second question.
39 physiotherapists had been killed in Gaza.
Yes, the physiotherapists. I wouldn't know. So this is a reported figure to us. I have to go back to, and I don't have it in front of me, on what was the HR on physiotherapy before this crisis, how many people have left, and now indeed how many people are not there. We know that in all areas, of course, there is this number, which what we know for rehabilitation, and maybe Pete, but maybe Thanos, because he worked on this in Limb and Reconstruction Center very much, that in the whole rehabilitation area was, of course, already let's say an area where the needs were far greater than what we could deliver. and the number of physiotherapies was always way too low. It's a completely different topic, but I want to still raise it. On mental health and psychosocial support, we have a mental health and psychosocial support from WHO, a specialist now in our team. And he traveled also to the north, and he met actually the only psychiatrist which was still related to doing some work in mental health there. So yeah, I think in all areas. Thanos, do you have any figure on the physiotherapists in Gaza, or can you tell a little bit about your experiences with a limb and reconstruction center in that area?
We don't have figures, and we don't have figures because we don't have the full image of the HR capacity in rehabilitation and physiotherapy before the war. However, we have figures regarding the level of disaster. So before the war, there were 3 designated physiotherapy and rehabilitation centers in Gaza that were responsible for the optimal follow-up of patients in need of rehabilitation and reconstruction. Right now, out of these 3 centers, none is operational. Especially when it comes to limb reconstruction center. Limb reconstruction center is not the building itself. We would love to say that it's a building, but in reality, for a multidisciplinary approach, it's the people and the functions. And the disaster to the entire health system has caused the entire limb reconstruction center to be non-functional. Walls are there, some beds are there, not its full bed capacity, but under no circumstance can serve its purpose. Moreover, we have to stress again that while we have clear figures on 39 deaths of physiotherapists in Gaza, we have 0 information on the number of physiotherapists that have left Gaza, have evacuated Gaza, and they make part of the big brain gain that Gaza is suffering from right now. So the big image is that rehabilitation services, and by definition, the entire spectrum of trauma services is decimated because of the decimation of the health system indeed. And this is why I think this exercise is super important, because we use the only solid input of data that we have, the one coming from the emergency medical teams, to extrapolate and finally have proper image of the level of destruction to the entire health system in Gaza. Thank you very much.
Thank you, Rick. Thank you, Dr. Thanos. Pete, would you like to add something to this?
No, just to echo those comments and to say, so the Rehab Task Force met this morning, and it was clearly articulated that there are 9 prosthetic and technicians now active in Gaza. So if you imagine we're dealing with several thousand amputations, it would take years for them, their current capacity to be able to meet the needs of just the newly injured population, never mind those with pre-existing needs that are there. So off the scale in terms of what can be done, and it's not just about supplies. Obviously, so supplies are a major barrier, but we need to have the workforce capacity and everything else to be able to scale up these services. So it's a huge issue. I just wanted to highlight on the 13%, that was around the assisted products needs. So that's around the need for crutches, wheelchairs, splints and prosthetics to go along with the injury. So that figure came from the shortfall there, which comes from our health cluster dashboard as a clarification. Thank you.
Thank you, Pete. Let's try to take a few more questions. Emma Farge from Reuters. Emma.
Hi, good afternoon. I wanted to know a bit more about the plan for rehabilitation services. It just seems challenging with the war still ongoing. I'm wondering, is it more of a plan or more of a wish? How would this work in reality? And I was wondering also about how big a health challenge is the dust and rubble that has been generated by the war, and how do you plan to tackle that? Thank you very much.
Thank you, Emma. I don't know, Pete, would you like to start with the first part of a question?
I can just say quickly, so the challenge with rehabilitation is that most of the complications for which rehabilitation are needed can be prevented in the acute and the early post-acute phase. So actually the need for rehabilitation services starts now and is not just about waiting for the reconstruction phase. So if we think about burns and the contractures that result from burns, if we think about all the complexities of these very, very difficult limb fractures that we have to face, spinal cord injury where people are quickly developing pressure injuries and bladder complications and things like that, these people are all developing these complications, which we can prevent at the moment because of the limited access to services that we have for the population. So it's something that starts now from this point, from the beginning of the conflict, and needs to be massively scaled up. But obviously the main barrier to anything to do with this at the moment is access and insecurity. But I hand over to Rick or to Thanos in terms of strategy in country.
Yeah, let me add something, and then Thanos might come in. So I think first part, I think what is really important is that indeed we struggle massively with data and assessments, of course, in the current situation in Gaza. So for me, head off that this assessment was done based on this data from EMT, and it's the best we can get, and an analysis made. I very much agree with you that is it a bit of wishful thinking? Yeah, I think it is a bit of wishful thinking. It's a bit of wishful thinking. First, that this is data sets, and the data are really, really grim when you look at it. And we have to, first of all, of course, we have to know, but also I think it will help us, and that's maybe a bit wishful thinking, that first it helps us, hey, rehabilitation should be an important focus for what we're doing now. Already what Pete says now, we cannot wait before there is a ceasefire and peace arrangement. We should refocus on it now, and what can we already do in the current context. But also it's very important that this planning, which is starting and which of course will be massively expanded when there would be a ceasefire and a peace arrangement. So how is this part of early recovery, rehabilitation and reconstruction within health? And rehabilitation needs are often a little bit forgotten. And in this case, we know we should not forget that. They should be also one of the many health priorities. And I think it provides the right focus on us. I don't know, Thanos, if you want to add something on this.
Thank you very much, Emma. So what I said before for multidisciplinary approach that's lost, this is what's missing here. And this is what Pete is highlighting, that to avoid disability and to make sure that your patients will be able to walk, run, make their living, have a proper life after a devastating injury, it requires rehabilitation that goes in parallel from the initial acute phase of the treatment. And what we're trying to show here is that, unfortunately, the impact to the entire health system is such that right now it is impossible to have a proper treatment plan when somebody is operated and then discharged from the hospital. Because right now we say that 16 out of 36 hospitals are partially operational. Partially operational is an overstatement, because this is how we are trying to reflect it. Partially operating hospital in Central Europe, for example, or in first world country means that we have a hospital that normally should be having ear, nose, and throat services along with the surgical services, but unfortunately they're not operating. So it's partially operating because it provides only surgical services. In reality, though, the surgical services and trauma services that are provided here right now in Gaza are limited and are done based on the availability of resources. And this means that if to save a limb, the only thing I have is an operation table, a surgical team, and somebody, a couple of nurses to follow up, then I go forward. I operate on my patient, I save the limb, I discharge the patient early because bed is necessary for the injuries that are coming. But unfortunately, I don't have the luxury, because right now it has become a luxury. And this is what we're trying to change here, to highlight that rehabilitation, physiotherapy is not a luxury. It's part of the treatment process. So unfortunately, not only figures look grim, but the overall result looks difficult. And it becomes a complex rehabilitation setup that it's really difficult to bring back to function, because not only supplies are missing, not only physiotherapy specialists are missing, but in reality, what's missing is a system that actually takes care of its injured in a way that includes all this approach. And coming back to the rubble, I think that other agencies or organizations have already highlighted that it's going to take years to remove all the rubble. There's a preliminary World Bank assessment that is far from encouraging, highlighting the need for proper removal of the debris. Thank you very much. Over.
Thank you very much, Dr. Tanos. And Rick, let's go to Euronews. We have Gabriela Golovin. Gabriela, can you hear us?
I can. Good afternoon. It's a question for Dr. Peeperkorn. What is the status of negotiations over a humanitarian pause for the second phase of the polio vaccination campaign in 4 weeks? What date should that resume? And what can you tell us about how logistically similar the second phase is expected to be to the first round? Thank you very much.
Thank you very much. So of course, the technical committee is currently already first analyzing, making plans, and that will be continuing over the next week. This post-campaign monitoring, but also analysis from everything what went well, but also what didn't go that well, where we can improve, etc. for the next campaign, including we will have better overview of, we will know much better what is the actual target population, both in the north, in the central, and the southern zone. We've had those discussions, of course, with all parties, and they are very well aware that in 4 weeks' time we start a second round. So the date is not yet decided. I think the technical committee is still analyzing. There's mentioned days of 14 October, but I think they still have to analyze that and plan, you know, what is the best day. We learned some lessons. Don't include a Friday, for example. First day is most important. Make sure that the first day everything is set up, etc. We will also have those ongoing discussions on this area-specific humanitarian policies. By then, I would hope that we don't need those discussions anymore. That our ceasefire processes have progressed, etc., and we are discussing a complete different type of campaign. But that's, of course, what we can all hope for. But yes, those discussions have already started, and when you say A, in this case, you have to say B. We cannot just do one campaign and then say, oh, the next campaign we forget. No, the next campaign, in this case with polio, we have to do, and we have to do as good or better as we did the first campaign. And I think we are ready for it. We can do it. And I want to make that point as well. I think that's it's amazing what has happened and what is possible when you have this area-specific humanitarian policies, not just especially for the children, but for the families, for everyone, and that this team can move around, etc. In some areas, it had, especially on this first day, I don't want to use that word, but it has even a bit of a festive, you know, environment. The children came out very well dressed, and many children on the streets which probably haven't been so joyful on the streets, which haven't been the case for the last 11 months. So if this is possible in polio, why can we not translate this for other areas? And this is a really important point I want to make. We are, and we were, and we are a little bit in a polio bubble. We still, and that's good, and we should make use of that. And I'm grateful of that. I want to make that point. But we need to extend that, of course, to all the other humanitarian priorities. We still talk about a lot of the same challenges we start for the last 11 months. If you talk about security, about getting the right goods and supplies, humanitarian goods into Gaza, the distributing those humanitarian goods across Gaza, a deconfliction mechanism which is not adhered to in a proper way, and which impedes a lot of those humanitarian missions. Actually, a lot of missions are cancelled, including our own missions. Over the last 3 weeks, we probably had 9 missions to the north, including many of those critically essential fuel missions for hospitals. of which only 4 happened. Now, if this is possible with polio, why can we not do that in a much broader area, and make sure that you establish these proper humanitarian corridors, even in a time of conflict? So I think it's a very good point, and we really have to push forward and learn the lessons. We are already discussing today, interestingly, with other UN agencies. People talk about planning for winterization while it's bloody hot the last couple of weeks. They're talking about winterization. They're talking about the lessons learned of this polio campaign in communication, in making sure people are aware, etc. How can we use that even for other programs? So we're already doing that, and we should continue. I hope, of course, it will not be needed anymore. There's a ceasefire, and peace processes are ongoing, and we can do it in an even much better and much more ideal way, and not just polio, but all humanitarian, because we still struggle in the humanitarian areas in health, in all the areas we mentioned, in water and sanitation, in food security, and specifically shelter. Over to you.
Very much, Dr. Peeperkorn. We are coming to an end, but let's take one last question. We have observer times from India, Ashwin Singh. Ashwin, you've been patient, so please ask your question.
Thank you, Tariq. First of all, we condemn the attacks on the physiotherapist, and we give a heartfelt condolence to the supreme sacrifice of those who killed in that attack. As per the reference, the provision of Part 2 of Geneva Convention cover the whole of the population of the countries in conflict without discrimination, and are intended to alleviate the suffering caused by the war. What action has the WHO organization has taken regarding the violation of explicit agreement in health between the warring parties? I recall Dr. Richard Peeperkorn discussing the terms and conditions of the agreement previously in the WHO conference. Thank you.
Thank you, Ashwin. I'm not sure what the question really is. I mean, the WHO is operating within the mandate, and our role is really to help the health system in Gaza do as much as it's possible. But I will maybe give the last word to Dr. Peeperkorn if he wants to speak on this, or just to make some last comments before we close the press briefing. Dr. Peeperkorn?
Yeah, apologies also from my side. The question, or the question was not clear to me. I mean, like, what is, what's the type of question, and a little bit similar to you, Tariq. As WHO, we focus very much on the how do we improve health all over the world, wherever we are. And then now I'm in Gaza, so how do we improve health in Gaza? And this is constantly the focus of our attention. Maybe I can say something about attacks on health and attacks on healthcare. So there's a mandate of the WHO, and we are mandated by the World Health Assembly to monitor, to analyze, and report on attacks on healthcare. And we do that in every conflict, in an acute conflict, in a chronic conflict, etc. We report on that. We regularly report on that. It's actually part of our weekly situation reports. We also have specific reports on attacks on attacks on healthcare. Important components, and of course, WHO, and this has been, of course, not only WHO but many partners. We are very clear that their health workers, patients, the ambulances, etc., should never be a target. I want to leave it there.
Thank you very much, Dr. Peeperkorn. Thanks to Ashwin from Observer Times India, and to all reporters who were with us today. And sorry if we were unable to take your question. You're always welcome to send us an email at media@who.int, and we will try to assist. So also just to remind you that we will send the audio and video file of this press briefing, as well as opening remarks of Dr. Peeperkorn, and we will send you full names and titles of our two colleagues who joined, Dr. Thanos and Dr. Deepak Kumar, technical officer with the WHO. With this, I will wish you a nice rest of the day and talk to you again soon.